Welcome to Newcastle Family History Society podcasts. The Newcastle Family History Society, located on Awabakal land in Newcastle, New South Wales, Australia, provides support for those interested in family history. Welcome to part 3 of How It Was, Advances in Medicine During My Lifetime, a podcast series that takes you through the extraordinary journey of medical progress narrated through the first-hand experience of Dr. Pamela Harrison OAM. In this final episode, Changes in Medicine, 1950s to 1990s, Pam reflects on groundbreaking discoveries, pivotal moments in patient care, and her personal contributions to the evolution of modern medicine. From early breakthroughs in cancer treatment and the rise of genetic medicine to the establishment of specialised services in Newcastle, this episode captures a transformative era in healthcare. Join us as we explore the milestones, challenges and triumphs that shaped medicine and made a difference in countless lives.
In 1958, as Chief Medical Technologist at the Manning River District Hospital, I performed a full blood count on a young woman inpatient and was shocked to find she had acute leukemia, a type of blood cancer which, at that time, was a death sentence. There was no treatment apart from blood transfusions, which temporarily relieved the symptoms of anemia but did not prolong life. At that time, there was no pathologist attached to the hospital, so I contacted one in Newcastle and sent him the blood slide and explained the situation to the patient's doctor. The pathologist confirmed my findings, and I wondered how the GP would be able to tell the patient her diagnosis. Little did I know that I would be giving similar bad news to my own patients in the years ahead, though by then I'm more often tempered with hope than was possible for that young lady. I remember the excitement on the day in 1960 when I was working at Guy's Hospital, London, and one of the pathology registrars rushed in to tell me that the Philadelphia chromosome had been discovered. This was an abnormal chromosome found to be unique to chronic myeloid leukemia, the first time a genetic abnormality had been found which was associated with a specific human cancer. It was a milestone in medicine, and it became an important test to confirm the diagnosis of the disease. Nearly 40 years later, the abnormality became the target for therapy, which can induce a remission, the term used when tests show no evidence of the disease. On returning to Australia, I studied medicine at Sydney University, graduating in 1969. During my time as a junior and senior resident medical officer at Sydney Hospital in 1969 and 70, I worked in the clinical and research haematology unit, directed by Dr. Frederick Gunts. Things had changed from when I made that diagnosis of acute leukemia in 1958. Dr. Gunts was treating patients with acute leukemia. It was early days with only one chemotherapy drug available which could be given through a vein, that is, intravenously. He combined this with another anti-cancer drug given in tablet form. Treatment was now possible because, thanks to the plastic bags now used in blood collection, patients could be transfused with blood platelets, which help the blood to clot when the treatment temporarily destroys their production. Previously, patients could bleed to death as a result of treatment. Infection was still a major cause of death, but now there were more antibiotics available. Techniques were also being developed to extract white cells from blood donors and transfuse them into patients to help fight infection. Patients were treated in a special isolation unit and barrier nursed to reduce the risk of infection. With rare exceptions, acute leukemia was still not curable, and not all survived the treatment. But remissions were possible, even though difficult to obtain. So there was hope, and more effective drugs were being developed. Dr. Gunts believed that the goal to curing leukemia was to develop therapies aimed at the individual patient's own cells. He has been proved correct, and, as with chronic myeloid leukemia, this form of therapy is being developed now, using agents targeting individual genetic or cell surface abnormalities in various cancers, including blood diseases, to achieve remission and for some a possible cure. Another advancement was the development of the ultrasound machine. In May 1962, a prototype ultrasound machine built by researchers from the Ultrasonics Institute was installed at the Royal Hospital for Women, then situated at Paddington. Both its design and clinical use was experimental, and over subsequent years there were changes in design and studies were made to check on its safety for use on pregnant women. By 1974, the machinery had been developed to such a quality it was produced commercially and exported around the world. I was appointed Haematology Registrar at Royal Prince Alfred Hospital in 1971. Specialties were just being introduced to pathology at that time, and I became the second person at RPA to study haematology special for the fellowship of the Royal College of Pathologists of Australasia. By the time I was awarded the fellowship, new haematology trainees had the option of a combined fellowship with the Royal Australasian College of Physicians. The world of pathology was changing. Immunology and genetics were important specialties. Automation in haematology and biochemistry had begun. Now, when a full blood count was ordered, a sample of blood was fed into a machine and it performed all the tests previously performed by hand, including red cell and platelet counts. It could even identify the types of white cells it was counting. However, it was not capable of identifying abnormalities, and blood slides were made and stained for each blood count. If any results were abnormal or it was clinically indicated, the slides would be checked by the staff and the haematologist. Well-trained and qualified staff are still essential to ensure the machines produce accurate results, to interpret the results, and to perform tests which cannot be automated. I returned to Newcastle in 1975 as Director of the Royal Newcastle Hospital and District Blood Transfusion Service, usually referred to as the Blood Bank. This service was part of Royal Newcastle Hospital then, but liaised with the Sydney Red Cross Blood Transfusion Service. In 1995 it was transferred to the Red Cross and is now a branch of Australian Red Cross Lifeblood. The staff greeted me on the first day with the news that they had started processing the plasma from some blood donations to produce cryoprecipitate. This was a recently developed way of concentrating factor VIII to treat haemophiliacs who had low concentrations of that factor, resulting in bleeding. The factor was in short supply at the time and was supplied under the strict oversight of the Sydney Red Cross Blood Transfusion Service. At that time there was no continuity of care for haemophiliacs in the Hunter district, and they tended to be treated at a hospital casualty department where, if they were lucky, the staff contacted the pathologist for advice. In the more distant areas they were cared for by their GP, who decided when to send them to Newcastle for treatment. Some had come regularly to the pathologist at the blood bank for help, so the staff had made friends with them. One of the young men had a hernia which was thought to need surgery. In the absence of a pathologist at the time, the staff had instituted a plan to produce cryoprecipitate to generate stocks to cover him for surgery, which they hoped I would organise in the next few weeks. RPA had pioneered a haemophilia treatment centre, so I was experienced in this branch of haematology and had to disappoint the staff by telling them that they had far too little to consider performing surgery at that time. I set about introducing a haemophilia treatment service for Newcastle and the Hunter Valley. I spent time educating the staff in the casualty department to always contact me if a haemophiliac presented there. Too often in the past, haemophiliacs presenting with an early bleed into a joint had been turned away untreated, only to return not long after with a major bleed, sometimes requiring admission, which early treatment could have prevented. I wrote a list of guidelines for the Casualty Notice Board and was available 24/7 if needed. A nurse had been appointed to the Haemophilia Treatment Centre at RPA to assess the patients during working hours in consultation with the haematologist, and she would prepare the cryoprecipitate or clotting factor and insert a needle into the patient's vein to infuse it. At that time there were no specialised courses for nurses as there are now, so when I asked the matron at Newcastle Hospital for permission for me to train the blood bank nursing staff to help me care for the haemophiliacs, she was surprised and reluctant to agree. I suggested she ring RPA and speak to the matron and nurses there. Soon after she rang me with her permission. The nurses were delighted. I would assess the patient, prescribe the treatment, and the nurses did the rest. This expedited the delivery of treatment, and the staff could see the benefits of their work in producing cryoprecipitate. The word spread, and in time most of the people with bleeding disorders from as far away as Branxton and Gloucester gravitated to the blood bank. As a result of centralisation of their treatment, affected families made contact with each other and they formed a Newcastle branch of the Haemophilia Society of New South Wales. They raised funds for more equipment for cryoprecipitate production. By the time I left the blood bank in April 1979, blood donations had increased from 11,000 per annum to 18,000 per annum, and Newcastle was virtually self-sufficient in cryoprecipitate, producing 9,000 bags per annum. This also reflected the motivation and concern of the blood bank staff in their efforts to supply blood and blood products to all those in need. When I was appointed full-time haematologist at the Newcastle Mater Misericordiae Hospital in 1979, most of the haemophiliacs followed me, though there I did not have the help of the nurses. After about 12 months, I approached Sister Mary Tarcisius, the CEO, for help, as my haematology clinics and consultations were growing rapidly and I had no medical or nursing staff to assist me. Sister Tarcisius appointed Sister Kay Sheridan, a Sister of Mercy and trained nurse, as the haemophilia sister, and she soon became competent in haemophilia care and support. When home care was introduced, she trained the patient and or the parents to insert the needle into a vein and give the factor at home for mild bleeds, or to continue prescribed treatment at home after being assessed and treated for more serious bleeds at the Mater. Social worker and physiotherapy support was provided by the Mater staff, and an orthopaedic surgeon cooperated in establishing an orthopaedic clinic to review joints damaged by repeated bleeds. Blood products as the source of clotting factor for inherited bleeding disorders have been mostly phased out now. They have been replaced with artificially produced factor and other medications which help improve and maintain factor levels. Some haemophiliacs, type B, have received gene transplants in recent times, and this is giving hope for for a more normal lifestyle in the future. The Haemophilia Treatment Centre still functions at the Calvary Mater, Newcastle, but now they care only for adults, and the children attend the centre at John Hunter Children's Hospital. Perhaps one of the greatest changes in medical practice in Newcastle and the Hunter Valley was achieved by a group of fundraising lay people who formed the Hunter Valley Cancer Appeal Committee and the general public who supported the medical profession in demanding that oncology and radiotherapy treatment be made available in Newcastle rather than patients having to travel to Sydney. This movement started in 1979 when the Mater submitted a request to the government for the introduction of these services for the Hunter region based at the Mater. At that time, the only care available to cancer patients at the Mater was through a cancer clinic held in the outpatients department. This was staffed by a visiting radiotherapist from the Prince of Wales Hospital in Randwick. Patients needing radiotherapy had to go to Sydney for their treatment. Patients with haematological diseases, which required chemotherapy, were prescribed treatment and admitted to hospital under a physician for an overnight stay to receive their medication. My appointment meant that haematology patients were transferred to my care and I treated them in my clinic as outpatients. As my patient numbers grew, I was able to enlist Sister Sheridan to assist me, this time with the intravenous chemotherapy. The field of cancer treatment was growing as chemotherapy was becoming an option for some cancers for which previously only radiotherapy or no therapy was available. Physicians and surgeons were specialising in this field, now called oncology. In 1980, the government agreed that oncology and radiotherapy services should be based at the Mater. Dr. Janice Bishop, the Director of Pathology at the Mater, had been largely responsible for writing the original submission, which achieved this welcome response. A working party for a Hunter Valley oncology group was formed at the Mater, which invited others to be involved to share information and to promote the introduction of oncology and radiotherapy services. My membership of this group resulted in my instigating and developing the Newcastle Mater Misericordiae Hospital Palliative Care Service in 1983, for which Sister Brendan and I provided a 24/7 commitment in a voluntary capacity until it was fully funded by the end of 1986. In a follow-on podcast, I will cover the details of the creation of this palliative care service. In May 1980, the foundations were laid at the Mater for the new Med 2 building, designed to accommodate the university medical staff needed for the Mater's teaching hospital role, radiotherapy and oncology services, and a new pathology department to support the latter. However, in late 1981, after the foundations were finished, the government froze the project, cancelled the building contract, and announced a study of medical services for the region to be undertaken by Dr. Olsen. As the foundations rusted, the public were outraged. The Hunter Valley Cancer Appeal Committee, which had been formed by Jane Durbin and was now led by Alwyn Holmes, called a public meeting at the Newcastle City Hall for 15th of December 1981 to protest the government's decision. Over 1,000 people attended. A Save New Med 2 committee was formed and local newspapers supported the fight by publishing articles explaining the need and publicising protest meetings held both in Newcastle and outside Parliament House. Over 70,000 signed a petition, and this was before the internet, which was presented to Parliament in support of the oncology and radiotherapy services for the Mater. In May 1982, after the government received the Olsen report, the Mater agreed to transfer maternity, neonatal and paediatric services to the planned new hospital, John Hunter. The building of the new Med 2 resumed with modifications to the plans. The ground floor could be used for oncology and radiotherapy services, but only if the public raised the money for the equipment. The people of the Hunter took up the challenge, and the first NBN telethon in March 1983 raised $1.75 million, an Australian record. Another telethon in 1985 raised even more. The state government had to keep its promise, and radiotherapy and oncology were established at the Mater. Sister Mary Tarcisius Ryan arranged an official opening ceremony for New Med 2 for the 15th of November 1985. Invitees included representatives of the public and those committees such as the Hunter Valley Cancer Appeal Committee, service groups, NBN, etc., who had worked so hard to achieve this result. And of course, members of Parliament were now happy to join in the celebrations of the new service, which some had previously opposed. Sister Tarcisius had a little surprise for them. The opening ceremony was held on level 3 in New Med 2, on the bare concrete floors of the empty shell which the government had refused to finish. Level 3 was not finished until 1990. In 1986, my additional workload of developing the palliative care service at the Mater meant I was finding it difficult to devote the time needed for the 45 registered haemophilia patients, so Dr. Jean McPherson, a haematologist attached to the University of Newcastle and the Mater, took over their care. I was surprised and gratified to be presented with a bronze medallion by the Newcastle branch of the Haemophilia Society of New South Wales, inscribed, "Thank you, Dr. Harrison, from Newcastle branch, 30th of the 6th, 86. By the end of 1986, the palliative care service was fully funded, and my unfunded 24/7 involvement was no longer needed. However, the haematology workload had continued to grow, and in 1987 a second haematologist, Dr. Sandra Deveridge, was appointed to the Mater. In 1991, the Royal Newcastle Hospital Haematology Department was transferred to the Mater and amalgamated with our department. This expanded the clinical role as they brought their expertise and resources to treat acute leukemia and perform bone marrow transplants, etc., as well as conduct research. When I retired in 1996, I said farewell to two branches of medicine I love dearly, haematology and palliative care. But I am grateful that I worked at a time when I had the opportunity of making a difference. I was fortunate to have people like Sister Tarcisius who listened to me and assisted me in making changes to improve patient care, and to have the support of those who worked with me. While this time of rapid advances and artificial intelligence brings many benefits, I hope the art of taking the time to sit, listen, and communicate with patients will always continue as an essential tool in both diagnosis and patient care.
We hope you've enjoyed Dr. Pam Harrison's remarkable journey through 4 decades of medical evolution, showcasing how innovation, perseverance, and community efforts have reshaped healthcare. There is one more story to be told, and in the next podcast, Pam will describe her involvement in creating and developing palliative care services in Newcastle and the Hunter. Be sure to join us again on Newcastle Family History Society podcasts.